Good evening. I would like to welcome everyone. My name is Allison, and I am delighted to have you join us. Before we begin, I'd like to mention that this conference is being recorded. The recording will be available on our YouTube channel in a few days. Also, while the chat feature is disabled, we encourage you to use the Q&A section, question and answer section, to submit your questions at any time during the presentation, and we will address them at the end. As we recognize Alzheimer's Awareness Month, I want to take a moment to highlight the incredible work at Alzheimer Group. As a nonprofit organization, we are deeply committed to supporting individuals and families affected by dementia. Through compassionate care, education, and support, we strive to empower those impacted, offering guidance, resources, and a strong sense of community. Our mission is to make a meaningful difference in the lives of those we serve, ensuring that no one faces this journey alone. With that in mind, it is my honor to introduce our keynote speaker, Dr. Howard Chertkow. Dr. Chertkow is a cognitive neurologist at the Baycrest Health Sciences Center. He is a senior scientist and chair in cognitive neurology and innovation at Baycrest's Rotman Research Institute. Dr. Chertkow is a professor in the Department of Medicine, Neurology at University of Toronto. And at Baycrest, he is also the director of the New Bank Family Clinical Trials Research Unit at the Kimel Family Center for Brain Health. His areas of research interest include early diagnosis of Alzheimer's disease and therapy of dementia using neuromodulation approaches. Dr. Chertkow is scientific director for the Canadian Consortium on Neurodegeneration in Aging. Did I miss anything? You're pointing, tell me what you're pointing at. Did I miss something?
CCNA logo.
CCNV, CCNA, I see. Okay. Oh, right, of course. Canadian Consortium on Neurodegeneration in Aging, CCNA. So without further ado, it is my absolute pleasure to introduce Dr. Howard Chertkow.
Thank you. Thank you very much, Allison. And I want to congratulate you and the AGI for the wonderful work you do. I spent many years in Montreal at the Jewish General Hospital, and all my patients had only fabulous things to say about AGI and the terrific work you've done over the years. So I'm just very pleased and honored to be asked to give another talk because I spoke last year. So it's not going to be quite the same as last year, so I hope people won't feel it's redundant. So with that, I'm going to share my screen. I'm going to be showing PowerPoint slides, and at the end, there'll be time for questions, I hope. And if you have any interest in volunteering to be part of our research, which we do in Toronto at Baycrest Hospital, but in Montreal, we have a research lab going at René Cassin CLSC at the Cavendish Mall. If you'd be available to come several times to Cavendish Mall to participate in our neuromodulation research, we're desperate to get people with no memory loss, with mild memory loss, and with mild Alzheimer's disease to come and participate in our research. So I'm going to be showing a phone number and a contact information, so get your paper and pencil so you can write it down. And with that, I'm going to switch to my slides. So we're speaking today on new diagnosis in Alzheimer's disease, diagnosis and treatment. That's a complicated title because it's a complicated subject. So I wanted to make it a little complex title. Now, when we give talks now, we always have to show who is paying for us. And this shows my funding support from Baycrest and the Canadian Institutes for Health Research, Western Foundation, the NIH. And one reason I'm in a hurry to get people into our research program is with the new government in the United States, NIH funding may not continue after this year. So we have to finish our NIH studies as soon as possible. And in the CCNA, we have many partners. And I'm also involved with many pharma companies. We carry out clinical trials of pharma-sponsored medications. So I've been involved with all of the pharma. No funding support has been received for this presentation. So without further ado, what we're going to do is talk about three main things. The new terminology for memory loss, because it's sort of confusing to patients and their families, new and future therapies to stop Alzheimer's, and advances in early diagnosis. So if we can cover those three things, I'll be very happy. This is the patient that Dr. Lois Alzheimer, his first patient with what he called Alzheimer's disease. And this patient had dementia. Dementia is a complex syndrome. We talk about three aspects and three different kinds of medication. There's a cognitive problem, a problem with thinking, and we give medications to try and improve these cognitive symptoms, the symptoms of memory loss, problems with planning and language. These are the medications we have now to improve symptoms. There are neuropsychiatric and behavioral symptoms, and we have about 32 medications to treat problems such as aggression, agitation, hallucinations, anxiety, depression. So we have medications for that that are used by doctors right now. But it's essentially dementia and Alzheimer's are a neurologic disease of the brain. And what we lack up till now has been medications to stop or prevent this neurologic brain damage from Alzheimer's disease. So this is the focus, the new medications that are arriving this year and in the future to treat the neurological brain disease. Now, I'm going to be talking about syndrome. I said dementia is a syndrome. And what syndrome means, it's a group of signs and symptoms that occur together characterizing some sort of condition. So that's a little vague, but this is, I'm going to use the word syndrome and I'm going to use the word disease. Now, what we have now, and people who are diagnosed with Alzheimer's dementia receive symptomatic treatment. These are medications to try and improve the symptoms. It doesn't stop the disease. And these are medications you are probably all familiar with: donepezil, rivastigmine, galantamine, and the Exelon patch. These are what we call cholinesterase inhibitors, and they produce modest improvement in some patients. In about a quarter of patients with Alzheimer's disease, there's no benefit. And really, the goal is to roll back the clock 6 or 12 months. Doesn't do more than that. There's another drug, memantine, totally different drug, different mechanism, and it also helps in people with moderate to severe Alzheimer's. There's a mild benefit, particularly for agitation. And this is really the armamentarium of what we have in memory clinic today. Uh, all symptomatic medications. Are these worthwhile? We think they are. I've been very involved in a number of Canadian consensus conferences on the diagnosis and treatment of dementia, and the recommendations that these medications available in Canada are effective or efficacious for mild to moderate Alzheimer's. They're viable treatment options and they should be tried. We don't have any evidence one is better than another, and we've been using these for about 20 years. Interestingly, there is scientific evidence that if you combine the two classes of medication, people deteriorate more slowly than on either one or on no medication. The reason we tend not to combine them is that RAMQ and OHIP don't want to pay for two medications together. So it makes sense to be on both, but also it's helpful if the government pays for them. So what we usually do is use cholinesterase inhibitors alone. Now, in many reviews, again, the important thing is to realize these improve symptoms, but they don't delay the onset or the progression of Alzheimer's. The disease still goes on and gets worse. And there are non-negligible side effects, but it's important to realize we haven't slowed the disease. We've improved the symptoms for 6 or 12 or 24 months, probably. So the important thing now is to develop new therapies in this decade to slow or stop or modify Alzheimer's disease. And we're right on the cusp of this new age where we do have medications that do affect the disease. And this is what I'm going to talk about. But first, there's going to be a digression. We've got to digress and talk about terminology, because this is to understand what's going to happen in memory clinics, you have to know the terminology. Now, we talk about in the memory clinic about cognitive syndromes, and this is sort of our first level of diagnosis when we see a new patient. Either the person is normal, that means they have no cognitive complaints, they don't have anything wrong with their memory when we test them. What are they doing in the memory clinic? They probably took a wrong turn and ended there by mistake, because if you're normal, you shouldn't be in a memory clinic. Now, some people start to have complaints about their memory, but if we don't find anything when we test them, their memories test as normal. We call this subjective complaints or subjective cognitive impairment. The second syndrome is we call mild cognitive impairment. We measure, we do testing of memory, and there is impairment compared with other people their age. But it's not enough to affect their day-to-day function. They say they're doing everything they used to do. They just have this problem with memory. For example, they have to write things down when they go to the store. So there's no what we call functional loss. And this is mild cognitive impairment, MCI. Then the third cognitive syndrome we call dementia. In this, there's significant memory loss and cognitive impairment sufficient to impair function. Now, these are syndromes. There's no blood test that tells you if a person is in these three, which of these three categories. And notice they overlap, and this is important. They're fuzzy. It's a bit of an expert call if someone's MCI or dementia. So when you go to see a doctor in a memory clinic, the first level of diagnosis, they say your father, your mother, your family member has mild cognitive impairment or dementia. That's usually what you hear. Now, what do we do then? That's not the end of the story, because the reason we're interested in these early syndromes is that they are often the precursor of dementia. So it's been found that if this is the time when we make the diagnosis of Alzheimer's disease, dementia in our memory clinic, on average, that person has had mild cognitive impairment for about 7 years. And before that, they were aware of subjective memory changes that weren't even picked up on testing for sometimes for up to 15 years. So this is a period during which there's something happening in the brain. Amyloid, for example, is being laid down. This means there are several decades in which we could start to intervene if we knew for sure they were going on to Alzheimer's disease. This is where we want to be starting the treatments. And this is what's going to be beginning, I believe, this decade. So we're interested in subjective impairment and mild cognitive impairment because sometimes, not always, but sometimes they're the precursor of Alzheimer's dementia. So what is mild cognitive impairment? The person has a memory complaint. The complaint comes from the patient or from the family. That we call as subjective. And then when we do the testing, we say the memory is impaired compared to normal people. That's objective impairment. What sort of testing? You can go online and test your own memory. There's something called Cognicity, which has been developed at Baycrest, which is available free, and people can do their self-testing, get a printout and take it to your doctor. And it's actually been scientifically proven to be reliable. Uh, Family doctors often use a test. I was involved in developing the MOCA test, but there are many other tests that can be used by your doctor. And they will show in MCI that the person's performance is objectively worse. Other than memory, usually the other cognitive functions are normal or about normal, and the function, the activities of daily living are pretty much normal. The person's doing everything they used to do. So if it is mild cognitive impairment, the second level of diagnosis is to try and determine the cause. Now, figuring this out, the cause, that takes expertise, not really blood tests or scans, although we use those to help, but it takes someone who's interested to go the next step, take a history, do a physical exam, and do tests. For example, the person, maybe they've always had a bad memory. It's just normal aging. Maybe they're depressed or anxious. It could be medications such as sedatives can cause mild cognitive impairment. Menopause, some women notice a deterioration in memory, and testing shows it's objectively worse. So menopause can cause MCI. Medical illness such as thyroid disease or kidney disease, vascular diseases such as diabetes or hypertension, high blood pressure. Alcohol or cannabis, if overused daily, can produce mild cognitive impairment as a symptom. Other neurological conditions such as Parkinson's, sleep disorders, if someone has sleep apnea or very poor sleep, that can impair their memory during the day. Someone who's always had attention deficit disorder, sometimes it seems to get worse in their 60s or 70s, and they present as MCI. But what we're really after is MCI, which is the beginning of a brain disease such as Alzheimer's. And this other terms for this are MCI due to Alzheimer's disease or prodromal Alzheimer's disease. Sometimes this is a retrospective diagnosis, but with the new diagnostic tools, we can make this diagnosis during life. So what is the other syndrome, the dementia syndrome? Well, that also has a general definition. It's a significant decline in thinking, usually memory, plus some other domain of cognition, such as naming or language or attention. And it has to be sufficient to interfere with day-to-day function. So it's a combination of decline plus functional impairment. So what does function mean? The person is having trouble doing things they used to do, like doing their banking, handling money, going to the bank at the ATM, paying bills, handling the household situation, traveling, driving, handling their computer, handling machines such as television or television channel changer. So something has changed. They can't do what they used to do. And this should be chronic. That means ongoing for months or even years and generally getting worse with time. So this is the syndrome of dementia. And this is what we diagnose by talking to the family, talking to the patient, testing their memory, and asking about function. Again, this is not based on a blood test. This is based on a doctor's evaluation. Alzheimer's disease and most dementias progress and change over time. And this is from Dr. Gauthier, who's now retired from McGill, but he defined that the earliest changes can be changes in mood with depression often, and then functional change in cognitive functions such as memory loss. Later on, loss of day-to-day function, inability to handle their own affairs. Later on, still often neuropsychiatric complaints such as wandering or agitation or yelling. And finally, the person loses the ability to walk, their motor control, and in the final stages may often just lie in bed. So the symptoms you're going to see depend on the stage of the Alzheimer's disease. So the second level of diagnosis involves the doctor trying to find the cause of the syndrome. So we've talked about in MCI, mild cognitive impairment, finding the causes. What about if the person has a dementia already? Well, then we try and slot them into three different categories. Very rarely, the person has what we call a reversible dementia, maybe 1 out of 100 times due to reversible causes. Their thyroid may be lower, their B12 level may be low. This is where blood tests and scans come in handy. We've had patients who presented with dementia, and rarely they had a brain tumor, a benign brain tumor that could be removed. So we search very carefully to not miss reversible causes, although they are rare. Other than that, about a third of patients with dementia have what we call motor features. They have paralyzed arms, they have Parkinson's disease features, and these are caused by things like Lewy body dementia, multiple strokes, multiple sclerosis. There are many causes of dementia with motor features. And the main thing is it's more than thinking and memory. The person looks like there's something wrong. They have trouble walking, balancing. These are the ones that families notice that there's something wrong. They don't look normal when they're moving or walking. However, in 2/3 of the cases, that's not the case. There are no motor features. The person strides into the room, walks well, their balance is good, and they look fine until you sit down and test the memory and discover the memory can be very impaired. Now, if it's a young person in their 40s or 50s, we think of frontotemporal dementia, FTD, which usually presents with behavioral problems, such as aggression or unusual behavior. So this is a different disease altogether. We're going to put this aside. Maybe this is 1 out of 20 of people presenting with this. The other ones have what we're going to call an Alzheimer's syndrome. They look well, their memory is very impaired, they have a dementia. We're going to be calling this Alzheimer's syndrome. That accounts for about 2/3 of the people with this large category of illness. So this is subdividing dementia. Now, why am I taking the time to do this? Because these people with an Alzheimer's syndrome, usually there's more than one problem in the brain. Sometimes it's pure Alzheimer's disease. If we look in the brain, we call this neurofibrillary pathology because there are neurofibrils, neurofibrillary tangles made out of tau protein, along with plaques made out of amyloid protein. Sometimes that's all you see in the brain, and pathologists who look at the brain after death will report this. Then at the far end of the spectrum, there are people with vascular dementia. When you look in their brain, you see strokes, you see blockages to blood flow, and it's a problem with blood flow, what we call cerebrovascular pathology. But in most cases, there's some sort of combination of the two, what we call mixed Alzheimer's with vascular. Sometimes the ratio is mainly the plaques and tangles. Over here, it's mainly the vascular, but this mixed pathology is very characteristic, especially with people who have dementia over the age of 80. Most of them have both kinds of pathology in the brain. We may call them Alzheimer's. There's probably a vascular pathology as well. And we're discovering this now that we're doing MRI scans in so many people. We can take people who have never had a stroke, and we see this on the MRI scan. These white blips here should not be there. They indicate a problem with blood flow. And sometimes it's what we call confluent. It's solid around the center of the brain. Sometimes we see it clustered in areas where there has been a stroke. Now, some of these patients may have had a stroke, but many have not. And they say, well, we've never had a stroke, but the MRI scan shows problems with blood flow. Often, but not always, these are people who have had high blood pressure and diabetes, or smoking, or raised cholesterol, or a bad family history with parents who have had dementia or strokes, but not all the time. The important thing is these are all treatable. We have drugs for high blood pressure, diabetes. You can stop smoking. You can treat your cholesterol. So these are essential treatments, especially treating the high blood pressure. I can't overemphasize the most important thing we can do to treat dementia and treat mild cognitive impairment is to make sure that the blood pressure is checked and treated, because about 1/3 of older people with high blood pressure aren't being treated, and many of them have never been diagnosed. So everyone listening to this call should think, when did I have my blood pressure checked? When did my family members have their blood pressure checked? Look, we live in a situation where many people don't have family doctors, but you can go to the pharmacy and have your blood pressure checked, and that way you know that it's still normal. So I can't overemphasize the importance of treating blood pressure in order to prevent dementia. So when we look in a memory clinic or memory clinics across Canada, overall about half the people in the memory clinic would be termed as Alzheimer's. Maybe 9% or 1 out of 10 would be termed vascular dementia. But look, a big group have this sort of mixed dementia that I referred to. And a few percentage are due to frontotemporal dementia and this other condition, Lewy body dementia, that looks a lot like Parkinson's. So these are really the main causes of dementia in people coming into a memory clinic. So what do we do when someone's in a memory clinic and we diagnose they have a dementia syndrome or an MCI syndrome? Well, we do blood tests to rule out and exclude the treatable causes. We check thyroid, we check kidney function, we do brain imaging a lot now with MRI because we don't want to miss these small strokes that may not have been suspected. And there's a scale called the Physicus scale where we actually measure the degree of changes in the deep white matter of the brain. Then there are other tests that are not routine but sometimes useful. EEGs, electroencephalogram, if we think there's a seizure, lumbar puncture, removing spinal fluid, because now I'll talk about later, we can test for amyloid, we can test for the tau, And we can get this done. We send our samples away to Providence Healthcare in British Columbia, but soon there'll be centers to do these measurements in all the provinces. And there's PET, or in Ontario, SPECT, because there are very few PET scans, and rarely we do genetics. So this is sort of the standard workup that we do in memory clinics. Now, what has changed, why am I talking about this, is that there's been a new approach, particularly among the research community, to think of Alzheimer's disease more and more not as a syndrome, a fuzzy clinical syndrome, but in terms of the underlying brain pathology. Now, this is a cartoon, but if you were to look in a normal brain, you'd see these important cells, the neurons that deliver the messages and the connections in the brain. But in someone with the Alzheimer's syndrome, you'd often see between the neurons what we call plaques full of amyloid protein. This shouldn't be there. It's probably bad. And inside the neurons, we see funny clumps called neurofibrillary tangles. And this is what Dr. Alzheimer saw in 1906 when he looked in the brain of someone suffering memory loss. So we see plaques and tangles. This is the neurofibrillary pathology. So what has happened in the past few years is a progression as it becomes easier to measure in the PET scan of the brain and in the blood. We can measure for this neurofibrillary pathology. And this has led a set of researchers supported by the Alzheimer's Association in the US to try and have revised criteria for diagnosis, which depends on the biomarkers. So we can look in the plasma, that's the blood, or in the spinal fluid, and we're looking for amyloid pathology. These are changes that indicate there's abnormal amyloid in the spinal fluid, or in a PET scan of the brain, we can look for amyloid. The tau, the neurofibrillary tangles are full of tau. We can measure, it's called phosphotau or p-tau in the blood, and we can do a PET scan that looks at tau. So the movement among the researchers has been to say we should call Alzheimer's disease someone who has these biomarker abnormalities. These are called biomarkers. So the movement is now to get away from just clinical syndrome. So there's now a divergence between clinicians who work in memory clinics and academic biomarker and imaging specialists, for example, who say there isn't any amyloid in the brain, then it's not Alzheimer's disease. So in order to get more agreement, what we're moving towards is this sort of approach that in the memory clinic, we're going to call what we're diagnosing Alzheimer's syndrome. So this would be someone with dementia without motor features. Remember I said they don't have problems walking or with their balance. They don't have frontotemporal dementia. We've done their MRI scan and their lab tests, and they look like, we used to call this Alzheimer's disease, but we're going to call it Alzheimer's syndrome now. And someone with mild cognitive impairment, we might call it mild cognitive impairment syndrome. But we can now, with biomarkers, make a further distinction. We can distinguish the about 2/3 of those individuals who do have amyloid protein in the brain. And these are the ones that Jack and that new publication say these should be called Alzheimer's disease, or if they're MCI, should be called MCI due to Alzheimer's disease. And that contrasts with the other 1/3 who don't have amyloid in the brain. So they look like Alzheimer's, but in fact, there are other entities, different proteins with tau protein, or this is with a protein called TDP-43, other conditions that mimic Alzheimer's disease with amyloid. So this is the distinction we can now make with biomarkers. So these 1/3 again have different brain changes, and they're not easy to distinguish between these two subsets. So why is this important? Well, up until this year, we've had drug treatments such as the donepezil and the symptomatic treatment where we treat everyone with Alzheimer's syndrome in the memory clinic. But starting now, we're going to start to get anti-amyloid drugs that will be reserved for this subgroup. So we're going to have to start distinguishing those with amyloid in the brain from those without amyloid in brain. And this is sort of the challenge that we have now in the memory clinic. So up till now, it didn't really matter, but going forward with the new anti-amyloid drugs, it will make a difference. So this distinction will have to be made if the person is going to go on the new drugs. So now I want to, before I get back to talking about treatment, I sort of have to take a moment to talk to you as patients and families and ask you, as you learn about treatments, you have to pay attention to who is telling you what is good for treatment, because information now comes from 4 different sources. You can get information from doctors and healthcare people who are really concerned about, giving you hope and caring for people as patients. You can get information from the scientists and researchers who are giving you information based on evidence and scientific evidence. But there's also a bombardment of basically salespeople who are giving you evidence based on trying to increase sales of certain treatments. And particularly on the internet, there are people trying to sell things for memory loss and Alzheimer's with a little bit questionable ethics. For example, if you would have done a search of memory loss up till this year, on the internet, the first thing that comes up is Prevagen. Prevagen, which is made from jellyfish, and they've sold hundreds of millions of dollars worth of Prevagen. And now it's been successfully prosecuted in the United States for fraudulent claims made that Prevagen would help Alzheimer's disease. So unfortunately, there are people trying to make money off of patients and families. And then their influencer. We now have Robert Kennedy, who's going to be in charge of the NIH, and who knows where they're getting their ideas that they're trying to spread. So more and more, you have to be careful that you're getting accurate information from doctors or scientists and not just from influencers. So what are we doing for treatment? Well, we've had several decades in which we've looked at different approaches to treating Alzheimer's disease. And I've listed them there. It's just a shopping list. But the point is, because there are many possible ways to treat Alzheimer's disease in the brain, there's more than one approach. Removal of amyloid is the approach which is now coming to the basically the marketplace with approval from the Federal Drug Agency in the United States, and now they're looking at the drug agency in Canada. But there are other approaches to treatment of the disease itself, which are ongoing and in clinical trials. So let's talk about these. Anti-amyloid immunotherapy involves giving injections, mainly, possibly it'll be soon pills or under the skin injections. And this is a PET scan showing amyloid, someone at the beginning of the treatment and after 1 year on a placebo, not much change, versus someone on a high dose of an anti-amyloid drug. After a year, the amyloid has been cleared out, largely cleared out. So this is based on the idea that amyloid is critical in causing Alzheimer's disease. If we can remove the amyloid, it will change the course. The first anti-amyloid drug that's going to arrive probably in Canada, and this may be announced within the next few weeks, is lecanemab, developed by Eisai and Biogen, and it attacks what we call the amyloid beta protofibril. And I'm not going to go into the details of amyloid, which is very complex, but the point is it does remove amyloid from the brain, and this was published in December of 2022, 2 years ago, study in the New England Journal showing that people on lecanemab, this is over time, over 18 months, and this is basically, you can think of the change from their baseline. The people on the drug lecanemab did not decline as fast as people on a placebo. Now, this is a large group of subjects, and this is sort of the average, but this was significant, and it showed that they were changing basically the progress. They weren't progressing as fast. Now, notice the line is not flat, although some people in the study did not progress and others continue to progress, but overall, they can claim a significant change in the rate of progression. Now, this is not only when you measure cognition, when you measure the person's function. This is a score looking at function, what they were able to do during the day. Again, the people on lecanemab did not decline as fast as the people on placebo. And this is statistically significant, and it can be replicated. And based on this, in several studies, the FDA approved lecanemab as a drug, Leqembi, in January, basically 2 years ago in the United States. A second drug called donanemab from Lilly looks fairly similar. Now, this might look more robust, but they chose their patients somewhat differently. So we can't really say that it's a stronger impact, although they got 35% slowing with donanemab compared with 27% for lecanemab. But because they chose their patients in a different way, we can't really say that one is better than the other. Again, they showed an impact on function, an impact on thinking and cognition. And they showed other graphs by looking at the line this way. They can look at how much this is called the disease modifying effect, how much it slows progression to some point which is significant. And based on this approach, they could say that over 18 months, they saved 5.3 months. It took 5.3 months longer for the treated patients to decline to the same level. So this is also a statistically significant and fairly meaningful effect. So is this a shift in the paradigm? Well, some people say yes. Before these anti-amyloid disease-modifying therapies, there was no meaningful way to slow Alzheimer's, and now there is. Um, Patients' families used to say there's no hope for the future, and now there is some hope based on the arrival of disease-modifying therapies. And frankly, from the medical point of view, med students didn't really like to look on a career treating people with dementia, but now there's new enthusiasm because there's something you can do. We used to talk about Alzheimer's disease as the only one of the top 10 chronic diseases of older people without any disease modifying therapy, and now that's not the case. So it's an important progress. At the same time, we have to recognize it's a modest clinical response. Ron Peterson at the Mayo Clinic said it didn't stop the disease, didn't make anyone better, it slowed progression. It's given intravenously. It's expensive, and we worry about whether Quebec and Ontario will accept to pay for these. In about a quarter of people, they got some changes on the MRI images called amyloid-related imaging abnormalities. Usually these were not serious, and most of them didn't even have symptoms, but it is a side effect you see on the MRI. And they look like this on the MRI. There can be swelling, there can be very small bleeds. Some people got headaches, and rarely people have serious side effects like seizures. So this is a consideration, but not enough to overshadow the fact that people did have a statistical benefit from the therapy. Perhaps more concerning is that not everyone got the same benefit, that this is a subgroup analysis of lecanemab. And the important thing, the only thing I'll stress here is that males got much more of a benefit than females, women, about 4 times as much benefit. So this has to be replicated and looked at in more detail. It's possible that different patients, not everyone's the same. Some people will get more benefit, some people have more risk. And so it may have to be personalized. So we can't just assume that everyone with Alzheimer's should be treated. And by the way, the people in this study all had mild Alzheimer's disease. There was no one with moderate or severe Alzheimer's disease. They had MCI and mild Alzheimer's. And then we have to look at the realistically in Canada at the price. In the United States, I may be a little off, but about $26,000 a year. The same price, and everyone with Alzheimer's and MCI took it, could be up to $6 billion a year on the drug budget, which is currently for the country $30 billion. Now, it's probably going to be much less than this. Many fewer people would be treated, but it is a high enough price that we don't know. We can't assume that even if it's approved next week by Canada's drug agency, we can't assume that OHIP or RAMQ will agree to pay for it. And when you roll in all the extra MRIs and doctor visits and PET scans, it's really a substantial outlay. So some people have said to me, well, I'll pay for it privately. And with the cost of things, we could be talking for an individual trying to pay privately if you went to the States could be up to $60,000 in the first year. Will people's private Medicare pay for it or medical insurance pay for it? We're not sure. So if it's approved by Canada's drug agency, it's not clear that RAMQ or OHIP will cover the cost. Hopefully they would, but we have to wait and see. It might take 2 years to reach that conclusion. At the same time, even if it becomes available, we then hit another bottleneck, which is Canada. If you look at the number of dementia specialists per 100,000 population across the G7, Germany is up here around 24, Canada's down here about 5. So we're very short of neurologists, geriatricians, and psychiatrists working in memory clinics looking after these patients, and we're going to have a bottleneck as there will be many referrals to specialists, because I really don't believe that family doctors can handle this new and complex therapy on their own. So projections have been looked at adoption of any disease-modifying therapy. In Canada, it'll take a lot longer than these other countries, which is rather sobering. So in summary, lecanemab and donanemab are sort of a single base hit. They're not a home run, a cure for Alzheimer's disease, but optimistically, it's the first step towards meaningful treatment, and we're happy to have this rather than no disease-modifying therapy. So what about other steps? Well, Alzheimer's and dementia are complex, multifactorial diseases. This is the amyloid, which I've talked about, the anti-amyloid drugs, but there can be drugs against tau protein being developed. Other mechanisms of causing Alzheimer's disease can lead to other approaches. And the brain is made up of neurons. Connections between them are called synapses. So synaptic deficits and neuronal death may be even better approaches to treating Alzheimer's disease, or most likely a combination of multiple approaches. That's in the brain, but we also have to think of the environment, that these problems in the brain are probably made worse by diabetes, high blood pressure, obesity, inactivity. So maybe a combination of lifestyle and medications is the way to go. And of course, we have to target each person's cause and mechanisms, which might be different. So it's complex. And the cures and best treatment are going to be complex. You should know there are other approaches to treatment which are coming along. For example, this is a medication that treats the sigma-1 receptor, totally different from amyloid and tau, and involves survival pathways of the cell, and early studies show also a benefit, 28% slowing of decline. This is a small study that has to be repeated, but this is totally different mechanism that looks promising. Another medication, bryostatin, again, it's an early, smaller study, but again, it shows persistent benefits. So, and it's looking at connections between cells, the synapses, and trying to restore lost synapses. So there are multiple approaches which may be beneficial and must all be pursued. So what about now? What can you do for your brain while you're waiting for these medications? Well, I've been watching football. Your brain, as you get older, is like the quarterback of a football team. It's under attack from the opposite side, just like we're under attack from bad proteins, free radicals in the brain, poor blood flow, inflammation, and toxins. But your brain's protected by what we call resilience factors, like cognitive reserve. So if you can have your defense line helping to protect you, like protecting the quarterback, and prevent the other side from attacking you, there are things that can be done now while we're waiting for the other treatments. If you look up on YouTube or the Baycrest website and put in Chertkow dementia prevention, it'll take you to 15 things you can do now to reduce your risk of dementia. And this applies to people with MCI, things that they can do. I'm not going to go over them all now, but it's worth looking at. So Chertkow dementia prevention on the Baycrest website or YouTube. And basically what I talk about is things that you can do to build cognitive reserve now, such as more exercise, learning another language, making sure you get mental stimulation and creative leisure activities, hearing aids, social contact, going back to school, going to lectures like this, things that you can do to try and build your cognitive reserve at any age. And exercise and fitness and getting rid of obesity are also on the list. So these are prevention strategies. At Baycrest in Toronto, we've opened the Kimel Family Center for Brain Health, which is open to people over age 50 without dementia who want they're first given an assessment to look at their risk for dementia, and then they're given a prescription of things they can do to try and prevent dementia. And this is our staff, very nice people. And we get them in exercise classes and lectures and better diet and art therapy and clubs to prevent social isolation. So there's a lot that people can do by impacting their lifestyle and getting educated about dementia risk factors. At the same time, there are even some drugs that are out there which are now in trials of being repurposed for dementia treatment and dementia prevention. Metformin, which is used for around the world for diabetes, it looks like people on metformin have a lower risk of getting dementia. It looks like people on Ozempic also are doing much better. They're getting neuroprotection and reduced tau protein in the brain, less brain inflammation. So Ozempic looks very promising. And the latest is PDE5 inhibitors like Viagra and Cialis, which men take for erectile dysfunction. It looks like these enhance brain blood flow and get reduced inflammation and get more growth of new neurons. Now, someone said to me, well, maybe it's because having more sex and prevents you getting dementia because you're in a better mood, but the mechanism appears to be independent of improved sexual function. So I'm not saying to go put yourself on all these today, but these are in the middle of phase 3 large studies that may show that these actually have a role in some people at least in treating early MCI or preventing dementia. Of course, Ozempic and Viagra are not cheap either. So we may again run up against the question of finances. So this decade, I expect to see a host of new disease-modifying therapies that will make it to successful testing and conclusion and release, but maybe they'll work best in combination. We have to personalize, find the combination that works best in each individual. How many will make it onto the provincial formularies, and who exactly benefits from a particular drug? These are questions we'll find out in the next few years. This is a digression for 2 minutes, but in my lab, we're trying a totally different approach to treat symptoms. And this is neuromodulation. And the brain is full of magnetism and electricity. And we're using a method called transcranial direct current stimulation, where basically we apply electricity over the brain, over the skull. Nothing goes into the brain, but it's low current electrodes. It's not like electroshock therapy. All you feel is a very slight buzz when we turn it on. It's not painful, doesn't affect you in any way, but we give this therapy while people are doing memory exercises or language exercises, and it works. We're putting on a anode and a cathode hooked up to a machine, and basically we've shown over the past 5 years in Montreal and Toronto that putting these basically sponges over the skull drives a low dose. It's like hooking you up to a battery for half an hour. We can drive the electricity to the area of the brain that is not working well and increase the electricity while people are doing tasks, and it improves their function over the next 4 to 6 weeks. So we've made unique progress in directing the electrical current to parts of the brain that we couldn't reach before. So we're very excited about this approach. We can show, for example, we've tried it in people with primary progressive aphasia. We can show treatment gives improvement in the language versus people on sham therapy get a decline over time. And so we can get a symptomatic benefit that people are aware of, the families are aware of, and it lasts usually about 4 to 6 weeks, and then we have to do it again. You have to come in for 5 or 6 or 7 treatments, but this is a sort of treatment that we hope in the future people will get the machines at home and continue to do this sort of treatment. So we're doing this neurostimulation therapy research program for people with MCI, mild cognitive impairment, mild Alzheimer's disease, particularly people with primary progressive aphasia. So if you know anybody with primary progressive aphasia, it's quite rare. It's a language problem due to Alzheimer's or another neurodegenerative disease. We want to hear about you. We want to get you into our treatment program. We're doing it in Toronto. And please, if you're interested, this is our contact information in Toronto, and this is in Montreal. In Montreal, we're doing it at the Cavendish Mall and the René Cassin CLSC, in Toronto at Baycrest. But we're also looking for people who are over age 65 who are normal. So if you're looking for something to volunteer over February or March, we have a driver who will take you, for example, in Montreal to René Cassin to Cavendish Mall. You go for an hour a day over a series of days. You do the therapy. We do an MRI scan, so you'll get to see what your brain looks like. And then we do this therapy, and you may improve in some way. We don't know, but you'll be helping research on Alzheimer's and research to find new treatments. And as I said, with the situation at the NIH, we're desperate to have normal, controlled people who can give their time for a few days to come and join us. So this is the phone number. This is the Jewish General 23621 extension for Chris Hosing, our coordinator, and Alice Zhang, and this is the email. So jot these down, send an email or phone us. We'd love to have you involved in February and March. We're desperate to get people. So the last few minutes, we'll talk about earlier diagnosis. As I mentioned at the beginning, we have a cognitive continuum, people normal, MCI, dementia, and I'm going to skip over this because of time. The question is, how can we diagnose someone as having Alzheimer's syndrome early on? And here we do the clinical evaluation, but we can now supplement this with early diagnostic approaches, which we call biomarkers. If you look in the brain of someone who's normal versus someone with Alzheimer's, this is called the temporal lobe. This is an area called the hippocampus, very important for memory. In a normal person, it looks like this, very plump. In someone with Alzheimer's, it's very shrunken. And we can see this with an MRI scan. Keep your eye fixed on this area. If we do an MRI scan, we can see the same area here. Here it's shrunken. We're looking at the brain stem and the sides of the brain. This is the midline, and this is the hippocampus shrunken. Not shrunken here, but in the stages, it gets progressively more shrunken. And this is a biomarker. Someone with mild memory loss whose hippocampus looks like this is very much on their way to Alzheimer's dementia. So we're measuring the shrinkage called atrophy. So we can do this just with an MRI scan. We can measure the size of the hippocampus on an MRI scan. And this gives us a biomarker for atrophy. Now we can also do a PET scan where we're giving a radioactive water, which is tagging the amyloid in the brain. Here you're going to see it superimposed on the individual's MRI scan. This is before we inject the amyloid ligand, and this is an hour later. We can see the amyloid lights up. You can see amyloid in this brain. So it looks like we've taken the person's brain out. We haven't. They're just lying in the MRI scan, and the computer reconstructs the brain in tremendous detail. We can see they have amyloid in their brain here. Now, amyloid is important because amyloid causes plaques in the brain, the plaques that Dr. Alzheimer saw. And this is the prevalence, this is the percentage of the population that has these plaques when we do PET scanning. This is PIB, this is the ligand that lights up the amyloid. And basically, we're lighting up amyloid 15 years before the person gets Alzheimer's disease. So the plaque is there for 15 years before they develop dementia. Now, the big progress now is that we're starting to be able to measure these things in the blood with a blood test without requiring to look at spinal fluid or do a PET scan using a new technique called single molecular array, or SIMOA. This SIMOA is a breakthrough because it allows us with great sensitivity to measure things at very low concentration. For example, if you took a sugar cube, 1 cube of sugar, tossed it into a swimming pool, waited till the next day and took a vial of the water, the SIMOA would say there's sugar in this swimming pool. That's how sensitive it is. So very low concentrations, very sensitive. So in this decade, we're having an explosion of blood-based and spinal fluid-based biomarkers, very sensitive with Simoa, relatively low cost, and a blood test is not invasive. There's one called Precivityy, which is being used in the United States, recently arriving in Canada, and others are coming. This will allow potential widespread and clinical use. This is going to help in early diagnosis. There'll be an amyloid blood test. Now, notice I didn't say an Alzheimer's blood test, because if the test is measuring amyloid, we've got to recognize something important, that not everyone who has amyloid in the blood is going to get dementia or get memory loss. This is the key thing I want you to take away from. This is Dr. Schneider, Julie Schneider in Chicago, looked at people's brains as part of the Rush Memory and Aging study, people who died with no cognitive impairment. They were nuns and priests. They had no memory loss when they died. When she looked at 170 of them in their brains, only about half of them, 45%, had normal brains. 29% of them had the changes in the brain with amyloid and tau. So they would have had positive amyloid blood tests. People who clinically, while they were alive, had dementia we call probable Alzheimer's disease. When she looked in their brains, only a very small slice had normal brains. 42% had the Alzheimer's changes, and another 30% had Alzheimer's changes with vascular disease. So that's maybe 3/4. So the people who had dementia all had changes in their brain, but the people who died with no memory loss, they still had a big number who had Alzheimer's changes in the brain. So we can't rely on just a blood test, because these would have had a normal blood test, and you couldn't have concluded they have Alzheimer's disease and required to go on medication. So we don't believe in doing these tests in people who don't have any memory loss, because this is what we call a false positives. This will tell us that they should be treated. Maybe they would have lived their whole life and never had memory problems. So we've had Canadian consensus conference on diagnosis, where we concluded that testing for amyloid in people without memory loss is not good medicine, it's not beneficial to patients, and may cause more harm than good. We want to test people with MCI, we want to test people with dementia. The problem is, in Toronto and in Montreal, we don't have good access to these biomarkers today. The amyloid PET scan is very limited. The spinal fluid measures are limited. The plasma biomarkers are very limited and not covered under RAMQ or OHIP. So we're in a bit of a pickle and not ready for how we're going to respond if we get access to disease-modifying therapies. So one approach is to realize that we're seeing people in the clinic with Alzheimer's syndrome. Predicting Alzheimer's disease with amyloidopathy is now a third level of diagnosis. And the testing you do as a clinician will depend on the degree of certainty that you need. For example, just with clinical markers that we've developed in our lab and others, you can probably be 80% sure who has amyloid and who doesn't. If you look at the plasma markers, that gets up to 92%. The spinal fluid gets up to 95%, and amyloid PET gets up to 100%. So using the new disease-modifying therapies against amyloid, we're going to have to get up to this level using biomarkers. But for the time being, probably 80% is good enough, because we don't have the medications yet. So this is the sort of situation clinicians will be in. This is our recent paper looking at clinical tools to assess amyloid. So all of this work is very important work, a lot of research still to be done. I'm very proud to be scientific director of the CCNA, the Canadian Consortium on Neurodegeneration and Aging, that is pushing this research ahead in Canada. And I don't have time to talk about CCNA, but we're supported by the Canadian government, Alzheimer's Society of Canada, many provincial agencies who want to see us working together to find the answers to memory loss and Alzheimer's disease. The take-home messages then: disease-modifying therapies are coming soon, but many questions remain. How soon will they come? Will they be covered by RAMQ and OHIP? Will they be appropriate or beneficial to you or your loved ones? We need objective scientific evidence, and the views of experts have never been more needed than they are today. The terminology around Alzheimer's has become confusing, and I've talked about Alzheimer's syndrome compared with Alzheimer's disease. There's been an explosion in the ways of diagnosis of dementia and memory loss. And now we have greater greater precision, but it's not necessary for everyone yet. We will have to more and more individualize the level of diagnosis carried out in memory clinics as the new disease-modifying therapies become available, whether 80% certainty is enough or we have to get up to 100% certainty. And I want everyone to remember not to ignore lifestyle changes and prevention strategies that you can do today. You can start these at any time of life. And exercise, cognitive stimulation, social stimulation, those are beneficial to everybody. So on that note, these are the people who do all the work in my laboratory in my group in Montreal and Toronto. We acknowledge funding support from all these agencies, and I hope if you stayed with me, that we can take some questions, and I'm very happy to take questions now.
All right. So I've been recording questions as they come in, and if anybody has any additional questions, please feel free to put them in the Q&A box. I will answer. I will ask you as many of the questions as I can. I'll try and kind of group them together, although that's a bit hard to do on the spot. But we do have some questions about what should be happening in memory clinics, what we should be expecting individuals to get in terms of testing and treatment, to make sure that the visit to the memory clinics are comprehensive, and also if a loved one would like the person to have that further newer testing, looking for biomarkers, things like that, is that something that most people should be advocating for, and how would you advocate for it?
Right.
That's kind of combining a whole bunch of questions into one.
Sure, that's good. So the first thing you should be expecting in a memory clinic is a wait to get in. And this is important because what can you do as a family member? Let's just say hypothetically, you have a parent who has memory loss. You've gone to the family doctor who does a MOCA and says, "Oh, the memory is down. Your father should be seen. I'm referring you to the Jewish General Hospital Memory Clinic or the McGill University Memory Clinic." You should expect a wait. But there's something important you can do as a family member. You can go to the family doctor and say, "Look, I know there's going to be a 8-month wait or a 9-month wait. Can you order the blood tests today that they will want and order the MRI scan today that they will want?" And the family doctor, if he says, "I don't know what blood tests," you call up the memory clinic where they've been referred and say, "What blood test would you like the family doctor to get?" And go back to the family doctor and say, "Order these blood tests." I showed the list. So if you go and watch the video when I talk about blood tests, but most family doctors know what blood tests to get, but encourage the family doctor to order an MRI scan. So then by the time it's done, they'll be getting into the memory clinic and you'll,
You're
save
already ahead of the game.
ahead
Yeah.
of the game.
Yeah.
So that's the first
Smart.
thing. You can expect to get a doctor who's very well trained who will do history and physical exam and look at the results and do cognitive testing of some sort. It might be different depending on the memory clinic. And then they'll go through the diagnostic levels that I talked about. Is this MCI? Is this dementia? If it's dementia, what kind of dementia? If it's Alzheimer's syndrome, as most cases are, or is it mixed dementia? And then they'll talk about many things that have to be approached. Things such as social elements, the person's safety. Are they managing on their own? Are they getting sufficient support? What about power of attorney? What about driving? What about financial situation? There are many issues that come up once you make a diagnosis of dementia, and they all take time. And it may be, you can expect multiple visits to discuss all of these issues. Everyone should think of question of power of attorney. If you have a family member who's got very mild memory loss, that's the time to talk to them about who would you like to have power of attorney and curatorship in the event that you get worse. Because if you wait too long, the person is no longer competent to legally sign to have their children take power of attorney. So these are the things to discuss when you're in the memory clinic. And then they'll often talk about use of the current medications, the symptomatic medications, and better treatment, if there's better treatment for blood pressure or diabetes, and other medications available for behaviors. So that is what you can expect from any memory clinic in Canada. Then you get to the next level. We don't have the disease modifying therapies available now. They're only available in the setting of research. So I know at the Jewish General Hospital, they're starting research studies of medications that are disease modifying therapy. So now is the time to contact them at their memory clinic and say, I'd like my parent to get access to these medications through a research study, because they're looking for people to go in with MCI and mild Alzheimer's. It's the way to get access to medications that may not be available or approved for several years still. So now's the time to go. I know about the Jewish General, but other memory clinics may be also doing these. So
Yeah, I think the McGill Center for Studies in Aging is also involved in
sure,
recruiting. But
that's
it's
right.
generally for people in the mild cognitive impairment or early stage Alzheimer's phase.
Exactly.
Yeah.
None of these studies are focusing on the later stages. And you just got now, even if the medications, excuse me, became available tomorrow, the hunch is that RAMQ and OHIP will say, well, they were only studied in mild patients. We're only going to approve them for people with mild disease. So I don't think you should get the expectation that the new medications will be made available for everyone. Um, and that's appropriate. Unfortunately, they're not tested in advanced disease. They won't be made available for advanced disease. So if you want to be in research studies, you have to accept the fact that some people will be put on a placebo, at least for the duration of the study, 6 or 12 or 18 months. Most of the studies then offer what we call open label. So everyone gets the real medication going forward. So I think you want medication, disease modifying medication today, and why wouldn't you, if you have someone who might qualify, find an academic memory clinic and say we want to be involved in clinical trials of early Alzheimer's disease. Now's the time to do it.
So I actually have, this is my question, but I'm going to jump in because it seems like a good spot for it. When these new medications were introduced in the United States, I was seeing some material on serious risks and side effects of being on those medications. Things like brain swelling, brain bleeds. How common are those kinds of side effects, and how much of a risk should people be
Sure,
feeling like they're
excellent question. So in the studies, about 1 out of 4 people roughly develop what we call the ARIA, amyloid-related imaging abnormalities. And basically, you can think of it, the medication was working so well at pulling out the amyloid, it caused a sort of an inflammatory response, we think, in some areas of the brain. So that's a quarter of the people, but 4/5 of those really had no symptoms or minor symptoms. So we're talking about maybe 1/5 of 1/4. So that's maybe 1 person out of 20 who went on the medication had significant side effects. Now, not everyone is at equal risk of getting those side effects. And we think that people with certain genetic appearance, people have 2 copies of the E4 gene, which is a risk factor for Alzheimer's, for some reason that we don't quite understand yet. People who have a double E4 at a higher rate of getting those side effects. And some countries that are approving these medications are saying people should be tested for E4. And you've got a double E4, you just don't go on the medication. And in the United States, they're saying, well, we'll tell people about they have a higher risk and then let the patient and the family decide if they're willing to take that risk. But again, in my personal experience, most of the cases of ARIA were mild. What it does mean is we have to do what we did in the trials, which is do an MRI scan before the person starts the medication. And if there's any evidence of what we call microbleeds in the brain, more than 4 microbleeds, that raises the risk of side effects. We don't let them start the medications. And we check with an MRI scan every few months in the first 6 months to see if there are any changes. If we see a lot of changes, we might hold the injection for a month or two. So we have to pay particular care on choice of patients and follow them with MRI scans. And if someone gets symptoms like they suddenly are getting a bad headache they've never had, we send them for an MRI to see if there's any of these changes. So yes, there in some and there were in most of the studies, 1 or 2 people who had a big brain hemorrhage and even death. So we have to accept that these are serious medications, but we're playing with a very serious disease. And this is a place where patients have to, and their families need to be involved, deciding does the benefit outweigh the risk for that individual person?
Right. And that's a big ethical question, right? We actually do have a question kind of about that. And I think that question is speaking to that ethical question, which is, if this is a progressive disease, why slow it down?
Well,
that's kind of me summarizing the question, but I think that's what the question was getting to.
We are in a country that believes in giving people autonomy for their life and their health. And I think that's a good thing. People should be able to make choices. And now with MAID, with medical assistance in death, people have the choice when we tell them, and this is some people, I've done measurements of amyloid. It is to say we're 100% or close to 100% sure that your dementia is Alzheimer's disease. And they may have seen the same in their father or their mother, so they know what that means. And they say, if you can't slow it down, I want to go for MAID. Either I want to end things now. And so the option of, well, a disease modifying therapy, maybe you'll be in the subgroup, because there is a subgroup that stabilizes over the course of a few years. I've seen that. So that does raise another option. And, the value of someone's life when they have mild Alzheimer's disease, what's their quality of life? Some of my patients enjoy their life, enjoy their time with their families enjoy them. They're spending a number of years with their children and grandchildren, and that's an individual choice. Is their quality of life make them happy? I've had patients who have died with Alzheimer's disease, and their families say, thank you for giving us 2 or 3 or 4 more years of meaningful life with our father or grandfather. So I think that, the nihilistic view that you have a progressive disease, what's the point of slowing it? You could say the same with heart disease or lung disease, or aging is full of chronic diseases and which are going to lead to death. So I don't think that we can just view, because it's almost ageism to say, because it's an old person with a chronic disease, nothing should be done. What we want to do, and our goal is to compress morbidity. That means trying to give an older person more years of meaningful life, meaningful function, meaningful interaction with their family, knowing that eventually they're going to get sick and get worse. So that's my response.
Is it okay with you if I jump in with a little bit more?
Sure.
Well, because my career has always been devoted to nurturing the mental health and mental wellness of people living with dementia and of their family caregivers. And when I have people who are recently diagnosed walking into my office for the first time, very often people are in a really dark place and they think that life will be suffering from this point on. And, I never tell people there will be no suffering, because we all have suffering in life, whatever is going on. And maybe there might be a little bit more, but there's also probably going to be moments of authenticity, joy, and life to be lived. And so just because we can't imagine what that's going to look like and how that's going to feel at point A doesn't mean we're not actually going to experience it later. Now, I don't know if that's rose-colored glasses, but I think I've seen it and I've lived it for 18 years working here. People can have really wonderful experiences and still have dementia, and those two things are not mutually exclusive.
I couldn't have put it better. You put it very articulately there, and I second that approach.
So moving back to the question, we have a related question to the question of those first diagnostic meetings at the memory clinic. We have another question about how often should follow-ups be done? What should be done at follow-ups? Is there any value to re-administering the MOCA? Is an MRI done only once at the beginning, or should MRIs be periodically repeated? And then I have another person's question that's kind of related to this, which is there any risks to having too many MRIs?
Okay, I'll start with the end one because that's easy. No, there's no risk of having multiple MRIs. Look, I think that each person's journey through dementia is different. Some people change very slowly over time, and some people with a diagnosis of Alzheimer's dementia aren't even worse 6 months or 12 months later. So how often they should be reevaluated depends on how the disease is going and what treatment they're getting. So when we start the cholinesterase inhibitors, typically we say, we're escalating the dose slowly. We'll see you back in 3 months to see if there's been improvement. And sometimes, we say, okay, come back another 3 months so we can ascertain there's been a benefit. Because they're for symptoms. If there's no benefit, there may be no reason to continue that medication. Another medication should be tried. So that's the first thing. So at the beginning, you can expect to be called back to the memory clinic after the blood test, after the MRI, at 3 months to see if the medications are working. And then who quarterbacks the care depends on the clinic, the specialist, and your family doctor, because the care of people with dementia can be done 80 or 90% of the time by family doctors. In Quebec, there's been a lot of effort. Howard Bergman's been involved with the Quebec Alzheimer's plan and trying to basically help training of people in the GMFs, the family practice groups, to have someone there knowledgeable enough in dementia that they can take care of quarterbacking the care, infirmière pivot, care coordinator, and many family doctors feel confident and able to handle the dementia just talking to specialists as necessary. Other family doctors feel overwhelmed by it and say, no, you have to be cared for at the memory clinic. And there is sometimes some tension. The memory clinic wants the patient to be followed by the family doctor. Family doctor wants follow up by the memory clinic. Often you have to individualize if once the person, if they develop behavioral problems that require new medication and adjustment of medication, then more visits are required. If things are stable, sometimes every 6 months or 9 months is sufficient for follow-up.
I think we're often seeing once a year here even now. But that's not saying people aren't seeing their family practitioner in between. We have a whole bunch of questions here, kind of all related, about genetic testing, the double E gene, who should be tested, how to go about getting tested.
Yeah, I skipped over this because of time, so I'm happy to talk about. So family history is important. If you take everyone over age 65, about 8% of them have dementia. Maybe another 8% have mild cognitive impairment. If you have one person in your immediate family, brothers, sisters, parents who has dementia, that increases your risk of having Alzheimer's disease dementia by 70%. Okay, almost double. If you have two people in your immediate family who have had dementia, say both parents, for example, that increases your risk by a factor of 4. So 4 times 8, that's 32. If you have 4 people in your immediate family with dementia, it increases your risk by about 15 times. So just knowing how many people in your immediate family, now, look, there's some people, I see people who are adopted or people whose parents died of heart disease at a young age, so they don't know what would have happened later on. But looking at a person's family history already is telling you a great deal about their risk. Now, if you do genetics, other than the very rare situation with what we call familial Alzheimer's, which has onset in someone in their 40s or 50s, that's very rare. Let's put that aside. The biggest risk gene in late onset, that means onset after age 65, is the E4 gene, ApoE4. And ApoE is a protein. There's an E4, an E3, an E2. Everyone gets one of these from their mother and one of these from their father. So you get 2 E4 genes that increases your genetic risk. But you usually already know you've got increased genetic risk because you have family members who have had Alzheimer's disease. So if someone says, what will I know more by having my E4 gene tested than I know already? I already know my father had Alzheimer's, my grandfather had Alzheimer's. Will I know something? I'm at high risk just by virtue of that. Will I know something more by getting the E4 gene tested? Well, maybe you were lucky and didn't get those bad genes from your parents, and that you could find out by getting the genetic testing, and that might be reassuring, but probably you'll have at least one of the E4 genes inherited. You might find out that you have 2. So will that change your life if you're a person age 50 with no memory problems? No, that's not going to change your life. You should still be exercising, watching your diet, no smoking, watching your blood pressure, all the prevention things you should still be doing. What about if you have 2 E4 genes, are you doomed? No, because we know that some people with E4, 2 E4 genes will live into their 90s and have no memory loss. So it's not a blanket. You're certainly going to get Alzheimer's disease if you have these bad genes, and you're not completely protected if you don't have the genes. So as clinicians, we say, so why would we do this genetic testing then if it's not going to change what the patient does or what the doctor does? Right now, the only reason to necessarily do genetic testing is if someone is going to go on these disease-modifying therapies, the anti-amyloid drugs, it's recommended we do it because if they're in the E4 category, they have a higher risk of getting side effects, and you'd want to maybe not use the drugs or at least discuss it with the patient. So that's the only obligatory. Now, we do genetic testing in some circumstances where we think there might be a gene or we're not sure, and it's very individualized and usually involves referral to a genetic specialist, but it's not routine. There's no memory clinic that routinely does ApoE testing on everyone. On the other hand, as many people know, you could go online and order 23andMe for $100 and they'll do your E4 testing. So if you really want to know, you can send away and get it done swabbing your cheek.
So there's no telling the future, even with genetic testing.
I think that's
we all
really
want a crystal ball, right? Only if the crystal ball says we'll be fine, though.
Yeah.
So we have another question here. I'm kind of asking you now the kind of not categorized questions. So this one is, in your opinion, how much do cognitive tests like the trail making test play a role in early detection compared to biomarker indicators?
Well, that's a good question. We have many ways to test, objective tests of cognition, and cognition includes things like memory and attention, but also what we call executive function and planning. And there are many tests of executive function. Um, and the more testing that's done, the more accurate it's going to be. So if you go to a neuropsychologist, they'll test you for 3 hours with 15 different tests. That's got to be better than doing a MOCA, which takes 10 minutes. So you've got a lot more information. So what is done in one doctor will choose the test that they know and they're familiar with and that they have confidence in. You can't really say that one test, is better than another. It's the combination of tests and the gestalt, because in addition to test scores, a neuropsychologist or a cognitive neurologist looks at how the patient does the tests, their interaction during the history taking, how they're speaking, how they're interacting. It's been shown one of the best cognitive signs is when you're asking questions to the patient and they turn to their spouse for the answer. They're so used to, you say, "What month is it?" And they turn to their spouse. Call this the head turning sign. And someone does that, I already am pretty sure they have a dementia. So there's a lot more than the choice of one test versus another test. There's a whole gestalt of expertise involved.
I have a question here about using hyperbaric oxygen therapy and if there's any validity to doing that, if there's any likelihood of seeing improvement.
Yeah. So, you know, 5 years ago was the last time I looked up hyperbaric oxygen, and I was not impressed with the results. I'm now told by one of my patients' families that, oh, there's new evidence about hyperbaric oxygen. I'm going to send you the new references. So um, there are, and unfortunately, I haven't come tonight prepared to answer the question on hyperbaric oxygen. I'll tell you what, if Karen, you get the email from this person, and I'll, do a review and get back to them because there are all sorts of therapies out there, and the question is how good is the evidence? And evidence can range from what we call anecdotal. My neighbor had it, and he seemed to be better to someone running what we call randomized controlled trials where you randomly assign someone to placebo versus oxygen. My last review of the literature, I didn't find any good randomized controlled trials. Look, they say in the art world that the more you pay for a painting, the more likely you are to think it's authentic. It's the same way in treatment. People pay a lot of money to have hyperbaric oxygen treatments, and they're often convinced that it's beneficial. So this is why you need scientific clinical studies and high level of evidence. Certainly, I'm not aware that hyperbaric oxygen has gotten over that hump. But maybe something came out last week or last month that I haven't seen.
Okay. Another one that I hear often is questions about the use of cannabis for treating anxiety.
Sure, there are studies, CCNA, some of our scientists, Nathan Herman and Krista Langto, have carried out important studies on nabalone and other forms of cannabis in people with Alzheimer's. It is something to add to the other 31 medications to treat behavioral problems. And in some patients, it actually was effective without making them worse. So I don't exclude cannabis. It's I don't think it works in everyone, and some people don't get a benefit or get more anxious, but it's something to speak to the doctor about if you have a family member who's got dementia with agitation or anxiety. It is one of the medications, not the only one, but one of the things that can be considered.
We have a question here asking you to discuss the theory that dementia is now considered type 3 diabetes.
Yeah, so first of all, I'm not even sure that dementia is one illness. It may be uh, different people with Alzheimer's have different mechanisms at work. This was one of the theories about Alzheimer's disease. It's not one that there's been pros and cons. So if it was a different type of diabetes, well, the idea is that what is diabetes? And type 2 diabetes, it's the cells in your body can't use sugar well. They're just resistant to insulin, which drives in the sugar and the cells. That's why the sugar goes up. If you give people more insulin, it gets into the cells. So the thinking is that maybe the brain also is not using sugar well. That makes it a form of diabetes. When we do PET scans where we can attach sugar to make it visible or radioactive, we see areas in the brain in Alzheimer's that aren't taking up the sugar. So that's some evidence maybe it is a problem taking up sugar. Stephen Cunnane at Sherbrooke University is looking at if cells can't use sugar, can we improve people by giving them ketones and ketogenic supplements, milkshakes, because ketones are different from sugars. And this has been an approach in saying, how about ketogenic diets? The only trouble is very few people can stay on a ketogenic diet. It's so awful. But ketogenic supplements may be a way to go. And the bottom line is that it's hard to assume that this is the explanation for everybody with Alzheimer's disease, but it certainly may explain the problem in some people.
Yeah, I think that for caregivers, it feels like it's a good explanation because I think so many people living with dementia start to gravitate towards sweet food, and some people almost obsessively because the way food tastes change, right? And so they're kind of trying to make things feel less bitter by eating things that are sweeter. And so I think for a lot of people, they gravitate to that explanation because there's this behavior that feels like it's associated to it that I think is probably just completely coincidental.
But I think the question reflects something which is very important to realize, which is that surprisingly, although we've been doing this research for 30 years, we don't have the answer as to what causes Alzheimer's disease and whether it's the same thing in every patient. So a lot of basic research work needs to be supported, and everyone should be agitating for more scientific research on Alzheimer's. Canada has been a leader in this area, but unfortunately we've fallen behind because in the States they've increased the research budgets. Canada has not.
So a couple of questions that came through the email when people registered. One is very straightforward, which is there an age beyond which Alzheimer's disease would not be expected to start?
No. Dementia, the risk of getting dementia goes up each decade. Now, the only difference is that in older people over age 80, there's almost always a vascular element as well. So technically, that makes it a mixed dementia and not Alzheimer's alone. But if you look in their brains, you do see the Alzheimer's changes. So it's Alzheimer's disease plus, even in people in their 80s or 90s.
We also have a couple of questions about the current medications that are prescribed. Is it common to be on more than one medication? I think you actually mentioned that during your talk, that it can be, but it's not often paid by the province. But also, what are alternatives if a person is experiencing side effects with donepezil? I think you kind of touched on both of these, but
yeah, I think there are. Look, donepezil can have side effects such as dizziness, or more usually stomach problems, loss of appetite, nausea, even vomiting and diarrhea. And that means that's something to be discussed with the doctor. There are other cousins of donepezil, rivastigmine, for example, which sometimes doesn't have the side effects. So the dosage has to be played with. The rivastigmine patch sometimes bypasses the stomach. So there are alternatives. So it's important to bring the side effects to the attention of the doctor and talk about alternative medications.
yeah. There was one more question, and I'm just trying to find where it was. Sorry, I lost it. I had it in my mind, and then I lost it. Oh, the question was, why would a person, I mean, it's kind of hard because it's very specific, but why would a person be diagnosed with moderate dementia but not have had an MRI? And I'm going to ask a follow-up question, which is, should that person's caregiver be advocating for them to have an MRI?
Look, the access to care is different in different parts of Canada, and it's much easier to, we feel that there should be some kind of imaging. In many parts of Canada, CAT scan is available and can be obtained by a family physician. And the difference in care between getting a CAT scan and an MRI is not very great. And for most of our purposes, in the old days, we'd say, yeah, CAT scan, we worked with CAT scan for many years. Now with the disease-modifying therapies on the horizon, the need for an MRI is greater than it was before. So I think that's something to discuss with the physician. It may not make a difference.
Well, that was our last question. I want to thank you so much. You put things that are really complicated and technical into very understandable language, and I really appreciate it. I've been taking lots of notes throughout your presentation to share with others. So thank you very much. It's such a pleasure to have you come and do this talk for us, get all our questions that have been building up all year answered.
Delighted to be here, and I'm very pleased that people have stayed with us, and you can go back and see the videos. Again, I hope you wrote down our email and phone number for volunteering for research. We're very desperate to get people involved in the next few months, particularly people who don't have memory problems, who would give their time to come out to Cavendish Mall and participate in our studies. So thank you in advance for that.
And Dr. Chertkow, if you want to email us all that information, if anybody wants to call the office, we can also send that out. I just wanted to remind everybody, for those of you who are new to AGI, give us a call, make an appointment with a counselor if you have any other questions that haven't been covered today, or if you just want somebody to talk to and talk things through with. Counseling at AGI is free, so don't be shy. It's very easy to get a hold of us. The same email you got your link from, you can send us an email and we'll give you a call back, okay? All right, thank you very much. Have a nice rest of your evening.